a case. And it is a educative program by EP experts, primarily from India, but will be from around the world. It's going to be a high-level EP and deep dive into electrophysiology and devices. I have termed this the series "How I Do a Case" because we want to hear from all the experts' mouths that how do they think about how to plan a case? What is the preliminary lookout? What is the data they get from the patient? How they plan for the case? How do they execute the case? And how they think of the long-term care? Not only in terms of simple arrhythmias, but also for complex problems. It does not necessarily mean that they're going to show everything about a problem, whatever literature or whatever has been mentioned. It is more about how they think about it and how they plan it. And it'll be great insights into people's minds, the EP experts' minds, to really understand the ways in which they go about things. Let me thank IHRS body and IHRS executive committee for making this possible. This educational program is being transmitted through the world, around the world. And Dr. Deepak Padmanabhan has worked really hard at it. I also thank Dr. Anup Gupta, who's our vice president. He's coordinated with APHRS. So we have APHRS members who would be joining. Dr. Rakesh Yadav, secretary, who's coordinating with the SAARC countries. Our neighbors look up to us always for these issues, and I think we should be the leaders and guide them and help them set up and to further their programs. So people from Nepal, Bangladesh, Sri Lanka, they are joining too. And Dr. Deepak has coordinated with the World Society of Arrhythmias. We are very happy to have Professor Tom Deering here, who has been a dear friend for long between HRS and IHRS. And he has joined us today. Maybe he can speak a word. It's late in the night for him. Heart Rhythm Society, Dr. DJ Lucky Reddy, and from PACES, Dr. Balaji and Dr. Molly. They are also with this program.
President Ajay Naik.
We have a great series lined up, and I think this educative program will help a lot of people around the world. Thank you very much for this opportunity, and let's start this program for today. First, I'm going to call up Professor of Cardiology and EP at JIPMER Pondicherry. And he's going to talk on the basics of EP, how to set up the lab, how he does SVT study. Let's hear his insights, and then we'll have Dr. Devendra Bish talk about Professor Tom Deering, a minute of for you to let us know your thoughts.
No, thank you very much for inviting me to join you. You know, it is an honor for me to be here. My relationship with you personally and with the entire HRS team, you know, stems back many years, and it's been, you know, a fruitful one. I've learned from you. I hope you've learned from us. And our goal is to, you know, really make this, just like you nicely said, a global, you know, opportunity for learning, especially for young individuals, bringing in experts around the world so that we can hear what different people think and how we work together to make the delivery of arrhythmia care better. So I think this is the first step in making it come about. I want to thank you and Deepak very much for putting this together. I think it has immense potential, and by doing it right, it has the opportunity to really advance care. So, you know, thank you, and I look forward to, you know, participating as time goes on.
Thank you very much. Dr. Balaji, Dr. Molly, a word if you're there online. I guess, Deepak, I think we can start. We can have Dr. Balaji or Molly speak in the end if they are awake at that point of time. So, Dr. Raja, now you will be on the screen and let's go ahead with this. Godspeed.
Good morning, everyone, and welcome to this first edition of this new teaching series from IHRS. We've designed this as something that's going to be very practical and useful to young EPs and trainees. So it's very humbling for me, and I think encouraging for the other junior attendees to see a lot of senior people here. So I thank Dr. Deering, Dr. Ajay Nayak, Kartikeya Bhargava, Shomu, etc., who have all joined us here. So in this, since there's going to be a series of talks focusing on electrophysiology studies, I thought we'll start at the very beginning with the basics. Electrophysiology is indeed a 1,000-mile journey. Even after 20 years, you find you're learning new stuff every day. And the first step that you start with is really the basics. And even before getting into the basics of electrograms and studies, I thought we should start with how you set up an EP lab and how you set up. So the flip side of that would be that probably a lot of this might be something you know already, but I'm hoping that at the end of it, you will come away with something new to think about and probably some new things, changes that you can make to your practice. Can I just request everyone to mute yourself so that we do not have interruptions? And if you have any questions, you can please put them in the chat box. I think one of us will try to keep responding to them. So we have a poll set up in this session, and so we'll just start off testing how these polls work and also to get a feel for what our audience is today. So you have three choices here. How many cases have you performed independently? 0, are you still in training and have not done any cases? Or have you done less than 50 or more than 50? So Deepak, can we have the poll on? Yes. So you have a poll on. Right.
I'll leave the poll on for 30 seconds, then hopefully.
Fine.
Great. And these are the results, Dr. Raja.
Okay, so more than 50% of you have done more than 50 cases independently, which means a significant number of you are fairly experienced EPs. And but that still gives us about 40% of 40 to 45% who are relatively new. So fine. We'll keep that in mind. So to start off with the setup, some points with how to set up the lab. I think if you're setting up a lab fresh, or if you're looking at revising your setup, one good thing to do, which we have also not done it, is to have the console outside the primary EP room. And what this helps with is reducing fluoro exposure. So only the operators stay inside the room. And so the others can stay outside. You don't need to wear lead shields, and that is ergonomically very beneficial. And overall, this is a better way to operate. Now, another thing that you can think about in the design is to have ceiling-mounted booms for anesthesia and for all the EP equipment. This is how it looks here. It looks a little cluttered, but if you see here, it's basically this whole boom is mounted from the ceiling, and all the stimulator, the amplifier, and the RF generator, everything goes on this. That again reduces clutter of wires on the floor, and that is helpful to do that. Try to identify what are cables which carrying signal data and what are the cables carrying power, and see that these are kept separate. So paying attention to small things like this when setting up the lab helps with having better signals and a relatively noise-free lab. So keep data and power cables separately. If they have to cross, you have to see that these are generally perpendicular to each other. Whenever cables lie parallel to each other or are coiled together, they tend to have more interactions. If cables are going perpendicular to each other, the interactions are less. Now, the cable, if you see from the patient, the cable that goes to the amplifier, that part is going still in an analog fashion, and from the amplifier it gets digitized. So this part of the cable, which is carrying the analog signals, try to reduce the length. So the amplifier should be as close to the patient as possible, because that is where a lot of the noise will leak in. And try to have a good earthing setup, dedicated earth for the lab, and all equipment should be earthed to this, so that that is an important source of noise. Now, when you have the control room set up outside, in the control room, you can have two monitors for the EP system. You can have a monitor for the 3D mapping system and the stimulator. And a lot of the sound systems usually have a push to talk feature, but there are systems which are always on. And for this kind of a setup, it's better to have a duplex always on sound system, so that two-way communication is always open. In terms of the procedure, it's always, of course, important to see the patient carefully before the procedure. You have to know the history, what the symptoms are, how frequent the symptoms have been, a basic physical examination, drug history. Anesthesia evaluation of all patients is preferable, and definitely for patients undergoing more complex procedures, or who may require anesthesia in between. During echocardiogram in supraventricular tachycardias, of course, you're looking for the basic echoes for LV function and valves. But specifically, things which you're looking for include septal defects, ASDs. Look at the coronary sinus, whether it's dilated, and look for Epstein's anomaly, sometimes which might be mild and easy. So each institute may have a different protocol for investigations, but typically all adults would have some blood investigations, and primarily to look at blood counts and renal function. If patient is on anticoagulation, of course, you'll want to know the PTINR. In children, there is no consensus on required investigations. These are usually not necessary, but most centers would do some basic investigations. And of course, always be there's going to be exposure to radiation. So women of childbearing age, you have to try and make sure that they are not pregnant. Patients on antiarrhythmic drugs, the usual protocol is to stop the drugs 4 to 5 half-lives before, except in specific cases where patients have serious arrhythmias which can recur if drugs are stopped, or it's a primarily an anatomic-based ablation where it's not important to stop antiarrhythmic drugs. Procedures usually should have a timeout, and unlike surgery, we don't have laterality is not an important factor here, but you should discuss the patient identifiers, identify the patient correctly, introduce all the personnel involved in the procedure, discuss what the procedure is going to be, and any allergies. Now, you can do cases only with local anesthesia. You can do all cases with general anesthesia, or with an anesthesia backup. But often we don't have an anesthetist backup for all procedures. And nurse-administered, physician-monitored intravenous sedation is an accepted protocol for these patients. We routinely use fentanyl and midazolam in a dose of 1 milligram of midazolam and 25 micrograms of fentanyl, given at the beginning of the procedure, repeated every half hourly as required. In the absence of an anesthetist who's going to monitor the patient, the onus of monitoring is on the staff in the lab, primarily on the main physician, and a monitoring nurse. Continuous monitoring of
10 नहीं यार, 9:30 मैंने वाइफ को बोला है कि 9:30 तक, मतलब मैं 10 बजे तक घर पहुंच जाऊंगा।
तो
साले 1.5 घंटे तो मेरे को देगा।
1.5 घंटे सॉरी
नहीं देगा, देगा 1.5 घंटे। हाँ तो कल का है ना वो तो हमारा।
Can you mute yourself?
अच्छा।
Continuous
ठीक है,
monitoring
आज
of
तो 9 बजे आ जाइए।
and blood pressure is important. Sedation may have to be avoided in situations where it can affect the inducibility of tachycardia, like some automatic tachycardias and idiopathic VTs. So, can we have a quick poll on how often you use sedation during your regular SVT EP studies? Do you use them never? Choice A, sometimes choice B, or always choice C?
Dr. Raja, is the poll visible?
Yeah, the poll has come up. So just want to get a feel for what everyone's practice is, because this varies in different places. And sometimes even with regular EP studies, we are worried whether tachycardia inducibility will be affected because of sedation, or whether sedation affects patient safety.
The results are shared.
Right. So the most people have chosen that they use it sometimes, and 25% never use sedation. Only 13% use it always. So I think the trend is more for people not using sedation on a routine basis, using it sometimes. Like I said, one of the concerns is during a SVT study whether sedation would affect inducibility. And we had done the small randomized trial of giving the sedation, the protocol I mentioned, and found that there was no effect on patient safety. There was no patients developing hypoxia or hypotension requiring intervention. Whereas there was a significant improvement in patient comfort. If you ask patients after the procedure, patients who receive sedation feel much better after the procedure compared to those who have not received sedation. So it makes a big difference. Whereas tachycardia inducibility itself is not different. So the percentage of patients who were non-inducible or had difficult induction, defined as requiring more than 2 extras or requiring isoprenaline, was the same whether you sedated patients or did not sedate patients. So I would make a strong case for regular SVTs for patients to receive sedation. It just makes the patient more comfortable and makes the operator also more comfortable. Anticoagulation is something to pay attention to for all left-sided procedures. It's indicated. For right-sided procedures, again, it varies by institution. There is generally no requirement for anticoagulation, and you can avoid it if your overall procedure duration is less than an hour or so. But there is definitely a small risk of developing DVTs in these procedures because of multiple venous access, and therefore it is fine to give a smaller dose routinely. So some centers would routinely give all these patients 5,000 units. We give them 2,500 units. Also, to be alert that even in right-sided procedures, if you're using long sheaths, you can have clots forming in the sheath unless you have. So you can have continuous irrigation running through the sheaths, or at least intermittent flushing. But in these patients, again, it is better to anticoagulate. If you have clots forming and then they come out of the sheath, you can have pulmonary embolism. Also, patients with a patent atrial septal defect, even if the predominant shunt is left to right, you can have intermittent right to left shunting, and they can have a paradoxical embolism. Again, safer to have anticoagulation for these patients. This especially is important in patients with Epstein's anomaly. Even if you don't specifically see an ASD on echo, they usually have intraatrial shunting. They usually have intermittent right to left shunting across the ASD, and often you require to use sheaths in these patients. So it's just better to anticoagulate these patients as if it was a left-sided procedure. Access, again, is something that individuals vary in how they do. Usually you require multiple venous accesses. Arterial access, of course, is required rarely in a few patients. Up to 3 to 5 venous access may be required. And the most common, of course, is the right femoral vein. In addition, you may need to use the left femoral vein. And then you can use the internal jugular vein. Or you can use the axillary vein, and we find sometimes the axillary vein is better because we're used to accessing it more commonly for pacemaker procedures, and also in terms of ergonomics and standing and guide and placing catheters. The internal jugular is a little more uncomfortable, again, both for the operator and the patient, whereas the axillary vein may be a bit more comfortable. And standard of care now is USG guided access, which provides better safer venous access. So our protocol is not to, we don't usually use jugular superior access. All the accesses are from the femoral vein. And if patients weigh more than 50 kgs, we put 4 sheets through right femoral vein itself. We've not had any higher risk of bleeding or thrombus formation with this. When patients are less than 50 kgs, we put 2 sheets on the right side and 2 on the left side. We use 2 5 French sheets, and these take non-deflectable quadripolars, which are placed in the right atrium and right ventricle, and we place a deflectable decapolar catheter 6 through a 6 French sheet in the coronary sinus, and we have a 7 French sheet which we use to place a His catheter in the beginning and then exchange for a mapping catheter. Post-procedure hemostasis for venous access, usually you do not require any closure devices. Compression is sufficient if there is no anticoagulation. If patients have been anticoagulated, you have the options of doing an ACT, waiting for ACT to drop below 200, and then removing sheets, or many centers, if the patient does not require continued anticoagulation, like if you have done a left-sided accessory pathway ablation, want to remove the sheets immediately, you can reverse with protamine. Also, more and more commonly used is to use a figure-of-8 suture or a Z stitch, which is somewhat similar. Basically, what all these do is bunch up the subcutaneous tissue and skin around the venous entry site, allows you to remove sheets very quickly and without the need for prolonged manual compression. Very important to pay attention to the imaging protocols you use. Of course, the primary imaging modality we use in the lab is fluoroscopy. You should use newer digital flat panel detectors which reduce radiation dose significantly. If you have access to a biplane, it is preferable for most EP procedures, because for most of these procedures we require to see a left oblique and right oblique views, and a biplane allows you to do these simultaneously without having to keep switching the C-arm all the time. And a lot of the newer labs have an integrated data display system, which is basically a large monitor where you can put multiple inputs. We can put your fluoro there, and then your real-time and review EP systems. If you have a 3D, eyes, echo, everything can be put on one single display. So when you have that, that is preferable. And so this, we don't need to necessarily do a poll, but one thing from the beginning which you should do is the radiation dose should be reported in the procedure report. And this should not just be fluoro time, because fluoro time is only a very rough indicator, does not really provide a fine indicator of the radiation dose of the patient. So in addition to fluoroscopy time, air karma, because air karma tells you the skin exposure and acute risk of skin damage from the radiation, and dose area product, which gives a better overall picture of the radiation dose received by the patient. Ideal is to report all these three in the report. And how to reduce radiation is some habits that you have to learn from the time you start to train. So cine loops are very rarely required. Most devices, almost all newer systems have a way to store the last ECG fluoro loop. So you can use saving the fluoro loop rather than using cine loops. And fluoroscopy itself, it's like braking on a car. You learn to tap and not to just keep press. Always just tap on the fluoro. You have this last image hold. So whatever was the image that is recorded comes up on the screen, and then you can look at that. If you want to see where your catheter is, you don't need to continuously press fluoro and keep looking at it. You just tap on it, look at it, and then you can again tap and see where you are. So once you learn to do that, you will see that you're significantly reducing your fluoroscopy use. And this is another importance of recording your radiation dose per procedure. It helps you audit your usage, compare it with others, and see how you're improving with time. Of course, shielding is important. So another quick poll. What frame rate do you use for EP studies? Or what do you think is a suitable frame rate for EP studies? 3.75, 7.5, 15, or 30 frames per second?
See a lot of people. I see most of our polls are stopping at 52% participation. There really isn't any negative marking here. So
yeah, we're not identifying people individually or giving you marks. I mean, this is just to get a feel for what people are doing so that we can discuss accordingly. So all of you, please participate.
okay, we want to end it right here.
Sure.
Sharing the results. I hope it's on your screen.
Okay, so that's very good, because almost 50% of you have said that you use a frame rate of 3.75 frames per second, and about 41% use 7.5, and 13% use 15 frames per second. So As you know, like in coronary angiography, I mean, 30 is not there, of course. For coronary angiography, the usual speed used is 15 frames per second, because you need to see contrast moving through the coronaries. The coronaries are moving with the with the heart movement, so you need that kind of a higher frame rate. Now, in electrophysiology, you're pushing in catheters and you're doing things. Things are moving very slowly. You don't need a higher frame rate. And just remember that each of those steps going down from 15 to 7.5, 7.5 to 3.75 is halving your radiation dose, because you're doing that many less frames per time. So for the same fluoro time, your radiation dose is going to be half or 1/4 if you come down to 3.75. That's very sufficient for EP procedures, and that itself can be a significant way to reduce your radiation dose. So if you're not doing that now, you should just start doing this from tomorrow. And electron atomic mapping is being more and more used in SVTs, and I think the principal use of electron atomic mapping in an SVT study is as an imaging tool. So it provides you a way of non-fluoroscopic continuous visualization of the catheter, and because that is the primary. So if you think that activation mapping or something is the primary role, you'll still keep doing a lot of fluoro. Once you learn that this is actually a replacement for fluoro, and this is also a visualization tool, when you're using an electron atomic map, your fluoro use should be very minimal. And of course, you may use echocardiography either as transesophageal or intracardiac echoes to supplement your imaging. Again, very important from the beginning as you train to learn to pay attention to ergonomics. People are worried about radiation, cataracts, and cancers, but should also be aware that people who spend a lot of time in cath labs end up with a lot of orthopedic problems, so back pain, spine issues, neck pain, or with finally arthritis of the knees. And this is because you're wearing a heavy lead apron, standing for long hours. So pay attention to ergonomics. Like I said, don't be inside the room if you don't need to be. If you can set up your console outside, sit without lead, you should do that. You can wear, if you can use floor or ceiling mounted radiation, where you can just stand and you don't have to wear it on yourself. You can do that. Two-piece suits are better because your the lower piece weight goes from your waist. And another important thing is to keep the table at a comfortable height so you're not stooping down when you're doing procedures. So we'll come a little bit into more of the EP itself. Catheters, we used to have woven Dacron catheters, but more catheters today are this polyurethane or other synthetic plastic catheters. And of course, the catheters come in non-deflectable forms with fixed curves, or with as a deflectable catheters, which may be deflecting in one direction as a unidirectional, which will come in different curves, or as a bidirectional. And the bidirectional, when there is a bidirectional deflection, these might be asymmetric so that you have a larger curve on one side and a medium curve on the other side. So be familiar with what catheters you have and what options they provide. The most commonly used catheters for regular EP studies itself are quadrupolar catheters and decapolar catheters. The quadrupolar catheters have 4 poles and the decapolar catheters have 10 poles. And there is some standard terminology for catheters. We call these by electrode pairs have some spacing, and then there is a certain spacing between adjacent pairs. So for example, this decapolar catheter you see here would be called a 252 because that indicates that within each pair, the electrodes are separated by 2 millimeters and 2 adjacent pairs are separated by 5 millimeters. Whereas this would be a 555 where all the pairs are separated by 5 millimeters. So again, be aware of what catheters are using and why you're using those. We'll discuss. So quick poll here. I think we can just have 15 seconds for this. Which is the correct naming of the electrodes? What you see here in A or what you see here in B? I'm sure most of you know this, but just as a quick poll.
There you go.
Okay, so we wanted, I think, 100% right here because this should be one of the first things you know as you're interested in EP. The catheters, the electrodes on a catheter have a very standard naming convention. So the most distal electrode is always electrode 1, and then you go on to 2, 3, and 4. So 90% of you were right, but 10% got it the other way. And you have a multiple choice of catheters. So like for a quadripolar, you might have 4 French quadripolars. Even for a mapping catheters, though the regular catheters are 7 French, you have 5 French mapping catheters also. So smaller catheters may be more useful when you have very small children and you want to reduce the size of the catheters you're putting inside the vein. They're also more flexible. They have lower axial force, so maybe the risk of perforation might be lesser. But they generally tend to be less stable and less maneuverable, not that easy to take into different places. And then, like I discussed, you have catheters with different spacing. Now, the smaller the spacing, you have more precise localization. Sometimes you might pick up some signals, very localized signals better, but sometimes a larger spacing allows you to pick up signals better also. So it's a little bit of compromise and something that you should know and use. I'll show you some examples later to show how this plays out. Ablation catheters, you have uni versus bidirectional. So bidirectional is better in some ways because, for example, if you're doing a fast idiopathic left ventricular VT and you want to get good contact with the left ventricular septum, when you go in with a retrograde approach, unidirectional, it's very difficult to get the deflection to take you towards the septum. And there, a bidirectional, because you can deflect the other way, it helps. So that way, bidirectional helps. But sometimes, if you're used to unidirectional, you built up your muscle memory like that, it's useful to keep unidirectional. So again, it's something that you should try out and see what you prefer. And again, there are different types of handles and controls. You can use those. Irrigated catheters, ablation catheters are always used on the left side because they reduce risk of thromboembolism. Irrigated catheters are also used in situations where you need to produce a deeper lesion, and irrigated catheters are also required if you are stuck in a place where there's poor perfusion, so the flowing blood is not cooling the tip of the catheter, so you keep getting temperature rise, inadequate power delivery, then again you need an irrigated catheter. So where do we put the catheters? So the usual EP studies, we put 4 catheters. So in the right atrium, we put a quadripolar catheter, and this is usually placed in the right atrial appendage, which provides a very stable place to keep the right atrial catheter. But it may also be useful to place the catheter in the lateral right atrium when you want to pace closer to the lateral atrial wall. Typically, this is placed in an AP view, which gives you a good idea of where you're going. And I know some operators get used to doing EP studies without a right atrial catheter. I would advise all people training to get used to always having 4 catheters when you're doing the study. And these become especially useful when you're doing concealed right preventricular, concealed right atrial wall axillary pathways, or with atriofascicular pathways, which you can absolutely even miss if you don't pace from the right atrium close to the pathway. So if you just keep CS, you pace, you may never realize patient has an atriofascicular pathway. For a coronary sinus, typically we place a deflectable decapolar catheter. Some people prefer a superior approach, so placing it from the internal jugular or axillary. Like I discussed, that access is a little more uncomfortable for the patient also, and for the operator to stand there and push catheters, although the CS entry is usually a little easier. So it's your operator preference. We usually put the coronary sinus catheter from an inferior approach. Superior approach may also be helpful in that it sort of stays away from the other catheters and doesn't get entangled that easily with other catheters. Typically, for entering the coronary sinus, you'll start with a right anterior oblique view where you reach the annulus, cross over a little into the ventricle, and then you keep septal torque towards the septum, which is, if you're going from a femoral approach, a clockwise torque, and if you're going from a superior approach, a counterclockwise torque, and then you pull back into the atrium, watch in the LO view for a leftward movement of the catheter tip, indicating that you're inside the coronary sinus, and then you enter the CS. Once you place the catheter, you try to ensure that your proximal most electrodes, 9, 10, are at the CS os very close to the septum. That gives you a good way to assess atrial activation to know whether it's eccentric or central. except in cases where you already have identified a left lateral pathway, it might be preferable to push the catheters inside so that you can get bracketing, which will help you with mapping better. For the HIS, we usually use a deflectable quadripolar catheter. We use a 252 spacing catheter. And as I'll show you, what you can do with this is in addition to recording a proximal and distal bipolar HIS signals, you can record a mid bipolar signal also, which gives you one HIS mid signal, which actually has a larger spacing and makes it easier to record the HIS signal. Make sure that your HIS signal has 3 signals, HIS, the ventricle, the HIS, and the atrial signal. If you don't have an atrial signal, one thing is that you're too deep and what you're recording is a right bundle potential. And the other reason why you should have an atrial signal is that it helps you look at atrial activity overall, because this gives you atrial activity in the anteroseptal part of the right atrium. So another quick poll. Now that we are going to place an RV catheter, where do you want to place the RV catheter? Do you want to place it at the apex? Do you want to place it at the base? Or do you want to place it midway between the apex and base? So A, B, C are apex, base, or midway.
We have the same 58 to 60% people voting. I encourage everyone to vote. These are your
right. So most of you have chosen apex, and about 25% say base and 15% say midway. So what are the pros and cons of doing this? Now, apex, of course, is a very the usual location we tend to put a lead in, and it's stable. But one is, of course, in the true apex, your risk of perforation is higher. I mean, there is definitely a non-trivial risk of perforation from a diagnostic catheter also. So placing in the true apex, one is that there's a small risk of perforation. Another important reason why you place place the RV catheter in the base is it helps you better differentiate between the different mechanisms, between the different mechanisms of supraventricular tachycardia. So when you look at the post-pacing interval minus tachycardia cycling, or if you're trying to put HIS refractory PVCs to identify axillary pathway, having a basal position gives you an advantage, and probably that will be discussed in later sessions where SVT maneuvers are studied. But having it in the base is better this way. So don't necessarily need to push it all the way to the apex. If it stays in a fixed position in the base, you can leave it. Or even if it goes a little beyond the base, but don't try to get it all the way to the apex. So usually we put a quadripolar catheter, and like I discussed, basal position is preferable for most SVTs, or at least when you have equivocal results with your post-pacing interval or with SAVA, or you're not able to pre-excite with HIS refractory PVCs, you're not sure, just pull it back to the base and repeat those maneuvers. So typically the catheters are placed in a right anterior oblique and a left anterior oblique view, and this is how the catheters will look. Once you have the catheters, these have a connector, and the connector on the other side ends in pins. So a quadripolar catheter will end in 4 pins, and a decapolar catheter will end in 10 pins. It is important for you not to leave all this only to a technician, but also to be aware of how these pins connect to a junction box and how they are displayed in the amplifier. So again, a sort of convention is that if you see this red wire, it indicates the distalmost pin. So left to a technician or left to somebody who's inexperienced, I've seen places where inadvertently this gets reversed. And then if you do this for the coronary sinus, for example, you may see a central activation and think this is eccentric activation. If you do it in the ablation catheter, you see that your distal ablation actually has a larger A, and then you try to pull back to get, and if you push it in to reduce the A, it's still not reducing. So you get some clues like this, but if you're misled, you can be looking at the proximal signal and thinking it is distal, so it can be misleading. So make sure that these connections are good. So so here, for example, the right atrium now goes as 1, 2, 3, 4. So these numbers is what you'll need to enter this into the amplifier, which I'll come to later. And so to get you a bird's eye view of how signals move in the EP lab, inside the patient's heart, you have the catheter, which is in contact with the myocardium, recording the electrical activity. It comes out to the other end of the catheter, where you have a connector plugging from there into a junction box. And these 4 pins go into the junction box. So each pin in a junction box is directly connected to one electrode in contact with the heart. And these go into the amplifier, which does signal modification various ways, which we'll discuss, including amplification, filtering, etc. And you can choose how to display these signals and record these signals. So they're recorded, displayed. These signals are also fed into the stimulator, which uses these input signals to synchronize the stimulation. And then the stimulator, whatever it provides, the output goes back through the junction box, through the catheter, to capture the myocardium. So how do we set up these signals? So before getting into how to set up on the amplifier, I wanted to discuss in a little detail on what are unipolar signals, what are bipolar signals, because it's important to understand these. So let's start with this first question. Which signal is more prone to noise? Which shows more noise, unipolar or bipolar, A or B? Okay, so 90% of you have said that the unipolar produces more noise, which is true. The noise tends to be a problem more in unipolar than bipolar. So the next question then is, why does the unipolar show more noise? Is it because the unipolar, or let's say, which is the most important reason why you get more noise in a unipolar? Is it because it acts as a wide antenna, attracting noise from everywhere? Is it because you use a wider filter setting? As we'll come when we discuss filter settings, you usually use a wider band of filters for unipolar. Is that the reason? Or is it because there is a differential coupling of noise to the two electrodes in a unipolar? So you can give your answers here, A, B, C. Okay, so most of you said because the unipolar acts as a wide antenna. All right, so so I have made this kind of very simple schematic to explain what is a unipolar and bipolar and why you have differential amplitudes of noise and far field in a bipolar versus a unipolar. Now, a unipolar basically records a lot of local activity, but it is also very sensitive to things happening far field. It picks up activity happening throughout the myocardium also. So it is also picks up far field activity. It also picks up noise. So basically records everything that's happening around it. And why does so the bipolar is really composed of two unipolars, because it is actually, if you think of it, it's the difference between two unipolars. So when you're recording a bipolar between electrodes 1 and 2, you can think that you're recording a unipolar on electrode 1, unipolar on electrode 2, and looking at the difference between these, this forms the bipolar. So why does this reduce the noise? Because noise, when these two electrodes are very close to each other, the noise is going to be the same on both of these electrodes. So it's going to be almost the same or exactly the same. So when these get subtracted, it will become 0. Okay. And similarly, far field signal that these two electrodes see is going to be very similar. So again, that is going to get subtracted to 0 or very small. Whereas any local differences, so there is a small timing difference between activation happening at the two electrodes, it is these local differences which gets amplified, so that the bipolar is very sensitive to local events and very insensitive to far field events. And the reason why noise is very less on a bipolar compared to unipolar is that you have noise is coupled to both the electrodes equally, which means that both the electrodes see noise equally. Whereas in a unipolar, one electrode is sitting there, one electrode is a reference electrode, so that noise is differentially coupled to the two recording electrodes. So you cannot remove the noise, because the amplifiers have a thing called differential amplification, where when the two electrodes are seeing something similar, that is not amplified. Whatever is different seen by the two electrodes, it is amplified. Here, because these are seen differently, the noise remains the same. Now, the two electrode configurations, bipolar and unipolar, have a different field of view. So like we discussed here, a bipolar is primarily sensitive to events happening just around it. So this is 1 and 2, and really it picks up events only happening here. Whereas a unipolar is more sensitive to events happening nearby, but also picks up activity happening from far away. But a unipolar can also be made to be much more sensitive to local events. And how can we do that? We can do that by filtering the unipolar. So normally the unipolar can be considered as an unfiltered signal, which means essentially there's no filter applied to it. So you need to put a low pass filter for the Nyquist limit. I will discuss that. But and the high pass filter can be zero. So it's called DC coupled if it is zero, basically. So unipolar is unfiltered because you want to pick up everything. But even though we say it picks up local and far field signals, these two signals are different in frequency. So the far field signals have a significantly lower frequency components, whereas the near field signal has a higher frequency component. So if you introduce a high pass filter so that you cut down all these lower frequencies, you will reduce the far field, and a filtered unipolar will act more like a bipolar. This can be useful in some situations. People have said that you can use this, for example, to record late potentials in scar. So in diseased areas, to record potentials, sometimes a filtered unipolar may have advantages over a bipolar. So this is just a quick experiment. We did this a couple of days in the lab in a SVT case. So here we have a quadripolar catheter in the His. We have a bipolar recording from 1 and 2, you can see here. A bipolar recording from 3 and 4, you can see here. So this is the typical closely spaced bipolar, crisp His signal, okay? And but sometimes the amplitudes are a little small because it's really recording things happening over a very small area. But this is a 252 catheter. So if you take the His 2 to 3 signal, this is a larger spacing, but still bipolar, and tends to pick up signals a little better, but you lose this kind of spatial resolution to some extent. For example, if you want to measure the time from the proximal His to the distal His, you can do it with this His 3, 4, and 1, 2, but 2, 3, the His will get a little smeared because it is recording it over a longer period. And you can stretch this further. You can record a bipolar between His 1 and 4, between the two extreme electrodes, proximal and distal. You will get a more smeared His signal, a wider His signal, but you will pick up the His more reliably. So as you keep increasing the inter-electrode distance, a bipolar starts behaving a bit like a unipolar. And you can record a unipolar also, and you can see that you can still see a nice His spike with the unipolar. So this is a unipolar recorded from electrode 3. But you can see in the unipolar that you have good recording of far field activation. For example, if you see the atrial activation, in a usual closely spaced bipolar, the atrial activation is just representing local atrial activation. The P wave onset is much before this. But whereas with the bipolar, you can see the whole P wave. You can see the far field P wave as it is coming here, and then the local atrial activation. But this is an unfiltered unipolar. And then you can filter the unipolar. So you basically filter it like a bipolar. And then if you do a filtered unipolar, you can see how similar it starts looking to a bipolar. So these are broadly the types of signals that we use in the lab. Essentially, we can use bipolar and unipolar, but bipolars can be very closely spaced, a little more widely spaced, and unipolars can be unfiltered or can be filtered. So unipolar is not just for recording. You can use electrode in a unipolar configuration for pacing also. And why would we do this? In what situation is it advantageous to use unipolar pacing over bipolar pacing? So a poll again, Choice A, is it useful for checking phrenic nerve capture? Choice B, for entrainment in SCAR VT. Choice C, for inducing tachycardia. So which is the clinical situation where this is most useful? So close to half of you have chosen choice A and 37% have chosen choice B. So the situation where it's really useful is in entrainment. So if you think of it, if you're doing a SCAR VT, we haven't discussed, of course, that kind of complex case, but suppose you have a potential during VT, you're recording a potential in diastole, and you want to know if this is part of the critical isthmus, you want to do an entrainment there. And if your entrainment shows characteristics suggesting this is part of the critical circuit, you want to ablate there. Now remember, ablation is going to happen in a unipolar fashion from electrode 1. Whereas if you pace bipolar, you're pacing from 1 and 2, and you don't know whether the finding that you got was from the electrode 2 or was from electrode 1. So at least theoretically, it makes more sense to pace unipolar, so that when you see a finding suggestive of this being the critical site, you know this is under electrode 1, and ablating there is really going to affect the same place that you paced at. So how do we set up the amplifier, and what does the amplifier do? Now the amplifier does a series of steps where it manipulates the signal that it is getting. So the signal is coming in an analog fashion, which is essentially a continuous signal. This is digitized, where it becomes a discrete signal. And then it's amplified, and amplification may occur before digitization. Also, you can have amplification and filtering of the analog signal itself, or this can be done on the digital level. And filters generally are classified as high pass, low pass, and notch. Little confusing terminology, because high pass is the lower side of a band pass, low pass is the higher side, and then you have the notch filter. So digitization is basically converting an analog signal, which is a continuous signal, breaking it up, because you're sampling it at specific points of time, and then you're measuring the amplitude of those specific points. And this is how a digital signal looks compared to an analog signal. So we're not going to go into too much detail, but just to understand that you have a resolution in the y-axis and you have a sampling rate in the x-axis. If your sampling rate is not sufficient, you lose important data like notches. If your resolution is not sufficient, also you can lose important data. So it's important to have good sampling and good resolution. Now, the other thing is, of course, you would know about the Nyquist limit and aliasing from echoes. So generally, your sampling rate should be at least twice the frequency of interest. Now, most frequencies of interest for us in an EP lab or in ECG and intracardiac EGMs, most usual signals would be about 100 to 200 hertz. So you would need a sampling rate at least twice this. But there is some other high frequency information, like you might have fractionated signals or His potential. So generally, our sampling rate is around 1000 hertz, so that you can record frequencies up to 500 hertz. And the amplifier has a very challenging task to do, because the signals that you're actually recording, the intracardiac electrograms, if you think of them, are extremely small. In even physiologic signals, like a His signal, can be small. In pathologic conditions, like in areas of SCAR, you may have critical regions, important signals, which are very small, which are just above the noise floor. And also, you're recording these along with other signals which are much larger. So the amplifier has to be able to handle signals of such widely varying amplitudes. And actually, the noise it sees even much larger than this. In a typical cath lab, there are multiple sources of noise. Now, the cath lab, of course, is shielded for radiation, and that shielding itself also provides some amount of electromagnetic shielding, so outside noise doesn't come in. But inside the lab, you have a lot of electrical equipment. All these leak noise into the patient. So multiple sources of noise, and the system has to try and reduce all this noise. So some of the methods to reduce noise: always try to decrease noise at source. So if your signal is noisy, try to identify what is the source. Sometimes it's so if you have, say, defibrillation patches put on the patient, it might be coming from the defibrillator. Unplug the defibrillator from the wall, see if that reduces it. If that reduces it, that socket into which you're plugged is leaking, and then you might have to change it to another socket. If you find this can even come from your pulse oximeter probe that you put on. See that all the equipment is just check if earthing any of the equipment reduces the noise. Try to find out the equipment from which noise is leaking in. And like I said before, see that your power cables and cables carrying data are kept separate. And if they have to come close to each other, that they remain perpendicular to each other. Minimize coiling of cables. So generally for cable organization, you need to coil cables, but try to keep this minimal. And again, this we discussed, you have to minimize the distance between amplifier and source. So again, as I discussed, the amplifier works on a principle of differential amplification, where it amplifies the difference between two inputs. So one of the things this means is that the noise level should be the same on two inputs. If you're recording a bipolar, both of them should be recording similar signals so that this can be balanced and removed. And so usually the connecting cable that comes from a bipolar, for example, there is tightly coiled cables. The cables are tightly coiled so that the noise, so this allows balancing of these two inputs. And this is also why if you set your ablation tip, if you start pacing from the ablation tip, you'll start getting a lot of noise on the ablation, because one electrode that you opened for pacing, that makes them unbalanced and introduces noise. So as soon as you finish pacing from that, you have to remove it from disable pacing on that, so that the noise will be reduced. And also remember that when you're recording unipolar signals, you're often using Wilson central terminal as a reference. So clean ECGs are essential to record clean unipolar electrograms. Skin preparation with dry abrasion is good to do. Any unused equipment should be switched off. Sometimes, like I said, sockets may be leaking. Good grounding is important. 2 return patches for the patient helps. Keep amplifier close to the patient. Pacing outputs, keep them close to threshold, because they introduce saturation and noise when you're pacing. Skin prep can be done with, these are specifically designed for skin prep, but more than swabbing with alcohol or cleaning with saline, dry prep like this, basically light abrasion to remove the dead epithelial cells is what helps. Sampling rates are usually 1000 to 4000 hertz, like I said. Most EP systems, 1000 hertz sampling rate is sufficient, but if you can go up to 2000 hertz or 4000 hertz, if your system allows that, when you want to see very sharp potentials like late potentials or Purkinje potentials. The more samples you go, of course, the more samples are also being written to storage and are being handled by the amplifier, so it becomes more load on the system and more storage space is going to be taken up. Now, this is a system, this is the amplifier page from Bard, but the same principles apply everywhere. Here you can see the sampling rate can be chosen, and this is chosen as 1 kilohertz, which basically means you're recording one sample per millisecond. And here the notch filter can be chosen to be disabled or to be set to 50 hertz or 60 hertz. For our country, we'll be using a notch filter of 50 hertz because that is specifically designed to remove the AC noise. And if you remember there, we plugged in HRA from 1, 2, 3, and 4. So here you can choose that the 1 would go to the negative, 2 would go to the positive, and you record a bipolar signal between these. You can name this bipolar signal as anything. And then you can choose what is the frequency cutoff you keep here. This is the low cutoff and high cutoff, otherwise called as high pass and low pass, and whether or not to use the notch filter. So what is the preferred low pass filter for ECG, or what do you use as the low pass filter for ECG? So low pass is the upper level of filter that you set. Do you want to use 20 hertz, 40 hertz, 100, or 200? So just take these as A, B, C, D. We can have a poll to see what you prefer. 20, 40, 100, or 200. Okay, so I think it's sort of equally divided between 40 and 100, which is fine, which is what so there are basically kind of two schools of thought, but at least you should know the compromise that you are doing with each of these. Now, 100 hertz is better in terms of a diagnostic ECG quality. So if you want to see the QRS well, you want to see the notches, and you want to see the waveforms clearly, 100 hertz is better. 40 hertz is better in terms of reducing noise because you don't even need a notch filter. Even the AC noise is coming inside that. So your noise will be less. You'll have a cleaner ECG, but you cannot use it very well for morphology, and morphology can be misleading. But both are used. I would say it's preferable to try and use 100 or 200 hertz. But if you find it very noisy, even after you try other noise reduction and with notch filters, then you can reduce it to 40 hertz, remembering that with that lower high pass filter, your that lower low pass filter, your ECG morphology is not going to be very good. So generally preferred is about 0.5 to 200 hertz. 0.5, 0.67, of course, is the ACC recommended high pass filter setting. Now the preferred so yeah, what is a preferred high pass filter for bipolar EGM? So for a ECG, we do 0.5 hertz. Do we do the same, or do we choose 5 hertz, 30 hertz, or 100 hertz for a bipolar electrogram? So choices are 0.5, 5, 30, or 100. Okay, so most of you have got the answer right, 30 hertz. So the thing is, because in a bipolar EGM, like we said, we are not very interested in low frequency signals, and therefore 30 hertz cutoff is enough. So bipolar signals, usually we do 30 hertz, and upper you can go to 250, 300, or 500 hertz. And unipolar signals, like I said before, the lower cutoff can be DC filtered, which means basically 0 hertz, or a very low value like 0.05 hertz. The upper can go to 300 hertz, and you can use filtered unipolar signals where you filter it instead of using DC 0.05, you use 30 hertz filter, then it's called a filtered unipolar. And notch filter is for AC noise, 50 hertz filter. Now, notch filter, remember that it cannot differentiate what is interesting signal and what is AC noise. So anything around a frequency of 50 hertz is going to be removed by the notch filter. So if your His signal or your Purkinje potential or a late potential has a frequency around 50 hertz, it's going to be reduced. So don't indiscriminately use the notch filter. Again, you can try and see if your signals are clean without a notch filter, then it's better. But if you use a notch filter, just be aware that pulmonary vein potentials also, for example, you may not be able to see, sometimes may disappear or attenuate when you use a notch filter. So yeah, I will not do polls here, I think, because we're already over time, but I'll just discuss a few things here. So this is a colleague had sent this axillary pathway ablation being done here, and you see pre-excitation. Bipolar signal looks good. Ventricular activation is ahead of the delta wave, but unipolar signal is looking positive, but could not get this negative. Since the bipolar looks good, ablated here, ablation is successful. So what was the issue? So these are the choices I had, but the point here is limb lead reversal is not going to invert your Wilson central terminal. Wilson central terminal is formed from all the limb leads. So the diagnosis here is that the unipolar looks inverted, and this means the connections have been made inverted in the amplifier. So this is sometimes missed, that the exploring electrode should be placed as the positive pole. So if we come back to this barred setup here, we have a unipolar here, and in unipolar, this negative has to be set as the reference and positive has to be set as the exploring electrode. If you set this up the other way, your unipolar will look positive when you really want it to be negative. So just remember to do this. And for this reference electrode, you can use the Wilson central terminal. If you find that your ECG has noise and that is corrupting noise and producing noise in your unipolar, you can change this to an in vivo reference, in vivo but extra cardiac. So you can pull one of your catheters down to the IVC and use one of those electrodes as the reference here. So a reference, so this is basically what I said. And a unipolar is extremely useful. Get used to setting up a unipolar in your lab and using it for all cases. And a good illustration here, while mapping an accessory pathway, in the bipolar, you cannot see an obvious difference. If I give you these 4 beats, catheter is slowly moving and ask you which is better, it's difficult to pick. But when you see the unipolar, you can clearly see the difference. You have a P, and at the beginning of the QRS, you have a small R here. The R progressively diminishes in height. By the last beat, the R is gone. It's a PQS. This is the ideal complex. So the unipolar can provide you a very good visual indicator of a good location to ablate. And there I showed you one unipolar, but we've moved to this setup where we set up 2 unipolars. So you a quadripolar catheter that we have for mapping, we have 2 bipolars, of course, set up. From 1 and 2 a distal bipolar, from 3 and 4 a proximal bipolar. But what you do is a unipolar, instead of just setting up one unipolar from distal, you set up an additional unipolar from proximal. Now the idea behind this is that whatever signal you see on a map distal bipolar can be arising from one of these. So for example, if you see an accessory pathway potential in the bipolar, you can now look to see where the potential is. If the potential is bigger in the uniproximal, that means your distal is not really right on the ablation site. You might have to pull it back to where the proximal is. So comparing these two helps. Even if it's not the potential, even just looking at the DVDT, the unidistal has a steeper DVDT compared to the uniproximal, tells you that unidistal is right on the place. Again, remember, unidistal is where you're going to ablate from. You're not ablating in a bipolar fashion. So again, this is an illustrative example from Murgatroyd's book, just showing how. So this is the usual settings. For an ECG, you go 0.05 to about 500, whereas for the intracardiacs, you start at 30. Now, if the intracardiacs also you do 0.05, what will happen is all these, you'll see these low frequency signals in bipolar, which you don't want. You don't want these far field repolarization signals. So the intracardiac has to be filtered at 30. But if you filter the ECG at 30, you can see how the P waves, T waves disappear. So the ECG has to be at 0.05. So it's a very good illustration of why you need this kind of differential setup for the ECG and the bipolar signals.
Dr. Raja, you can continue your session. This is a fantastic session. We can, you don't need to hurry it up. And we'll do Dr. Devendra's session during some AVNRT session another time. So you can go systematically. This is really important.
Fine, sure. So anyway, yeah. The other is now in the amplifier, if you come back here, so either in the amplifier screen or in the display itself, you have the ability to set up gain for each signal. Now it's some principles, I would say, on a ECG page, set equal gain for all the ECGs. Because if you have differential gains, your assessment of QRS axis is going to get thrown off. So you can easily gain something differently and think QRS axis is something else, or your assessment of transition, everything is going to be dependent on all the ECGs being gained equally. So see that the gains are equal. Also, in your mapping signal, generally it's preferable to put the same gain for map distal and map proximal, because you're always comparing a map distal signal to the map proximal signal and adjusting accordingly. If your gains are different, again, it can mislead you. Other than that, it's all right to have differential gains, adjust them independently. Even each of the CS electrograms, you can have set up different gains so that you can see the signals that you want appropriately. As you keep gaining up signal, for example, in a hiss, the hiss signal itself is small. So you gain up the hiss to see the hiss signal well. What happens is the atrial and ventricular signals now become too big. They overlap everything else. When this happens, you do what is called as clipping. So all the systems have an ability to clip. Now, different systems, some systems allow you to clip at variable levels. So you can set what amplitude you're going to clip at. Some systems like the Workmate gives you 1 or 2 levels of clipping, and some systems may just say clipping on or off. But basically, this is where you can use clipping. Okay. Now, as you keep increasing the gain, remember that you'll also see more noise. Sometimes as soon as you see a signal, you see a lot of noise in the signal, you can understand that this signal has been gained up a lot. So if it's, for example, the RV, it might be gained high and clipped also, then you can just gain it down so that the noise comes down and then you don't need to clip it. Or if really the signal is also that small, then you can see whether you need to reposition it to a place which has a better signal so that you can have less noise. So always set adequate gain to see the signal of interest without clipping. And when you have small signals, this becomes important when you're doing SCAR-VT mapping, etc. So what is the gain that you should set? So there's no magic number. The best way is to keep gaining it up till you see noise, and then just gain it down one step. That way you see that anything that is above noise you will see, because I think the general principle in a pathologic heart is any signal that is higher than noise can be important, and you should be able to see it. So for that, you should make sure that your gain is sufficient that you will just see noise. So clipping, like I said, is used to avoid overlap of signals. So typically you need to clip signals which are using for pacing, because a pacing spike will overlap everything else. And you need to use clipping for signals where one component of the signal is too large compared to other components, like in the hiss. And the amplifier has something called saturation, which means the amplifier actually has a certain amplitude limit. If you're gaining a signal or you introduce a signal which is very large, more than that limit, then the amplifier is trying to push up its output to that limit. So for example, you put a pacing spike. So when you put a pacing spike, that's a very high voltage signal. Now the amplifier, when it pushes it up that much, for it to get back to a lower level and be able to see a signal that comes after pacing will take some time. And this you will see on the signal. I don't have an electrogram here to show that, but you'll see it as a sort of plateau after your pacing spike. Tells you that the amplifier is saturated, and this saturation can be reduced by clipping it. If you clip it, you tell the amplifier, even though the signal is going above 5 volts, you don't need to push your output that much. So that helps you see the smaller signals which come later. But clipping is again something which you should not use in certain situations if it is going to hide your signals of importance. And sometimes because of clipping, a signal which is bifid may be seen as a single signal, and where you need to compare AV ratio, for example, clipping can obscure the true AV ratio. So I'll show you some examples of that. So this is a situation where we use clipping. I want now typically when you place from a femoral approach, the CS catheter records large atrial signal and very small ventricular signal. And that is sufficient for us most of the time. In the CS, our interest is in atrial activation. But here is a case where you're doing antegrade mapping, you're mapping a left-sided pathway antegrade. And so we want to see the ventricular activation in the CS. So then you have to gain up all the CSs. Now, when you gain up the CSs enough to see the V signal, the A becomes very large, it's overlapping, then you clip them. So this is the classic signature of clipping. You see this very rectangular cutoff, then tells you that the signal has been clipped. But definitely don't clip ablation signal. So if you clip an ablation signal, you see here, it just looks like one chunk, one block of signal here. Whereas if you remove the clipping, you can see this is really a A followed by a V, and there's a pathway potential. And see, by clipping it, you can just lose this kind of information, whether this is two signals or one signal. You can also, by clipping, this looks like A and V are equal in height, right? So these two look similar, but when you unclip it, you can see that the A is large and V is small. So almost never clip mapping signals. So because you need to be able to assess AV ratio, and you need to be able to assess the different components of the signal. In the display, you have to set up specific pages, and this is individualized. You can set it up according to how you want it. But some standard patterns are to set up an ECG page, an intracardiac mapping page, or an intracardiac page where we do the main EP study and everything, and then a separate page for mapping ablation. And what we also sometimes do is have an all page, because in some systems, if you have, for example, you have an intracardiac page, and you in the intracardiac page you have 3 ECG channels, but later for publication or for presentation you want to add a 5th ECG channel. It might be difficult to do in that. It may not allow you to retrospectively add a signal on a page. In that case, you have an all page which has all the signals, so that you can have any permutation of signals that you want. So we sometimes have an all page which will have all the 12 ECGs, all the intracardiac channels, and use it just primarily for being able to export or present a tracing which includes all the signals that you're interested in. So an ECG page typically just has all the ECGs in the order that you want. And like I said here, just see that they're all gained equally. And when you have colors, you can set V1 to a different color so that very quickly you can know from where the limb leads end and the precordial leads start. For an intracardiac page, so almost everyone would set 3 or 4 ECG leads. And this is at the minimum, I would say, as a standard is to use 1 AVF V1. These provide a sort of pseudo orthogonal 3 leads. So one provides the x-axis lead, AVF provides a y-axis lead, and V1 provides a z-axis lead. It's also like 1 and AVF together give you the frontal axis, and V1 tells you whether there is if there is a white QRS, what kind of underbranch block pattern it is. So generally these 3 leads are sufficient, but you can in individual cases use additional leads. You could use V6 on a routine basis. A lot of septal pathways, it's useful to use V2 because you'll see the rapid transition, and the loss of R wave in V2 might be a good way to quickly identify that pre-excitation is lost. So if you have pre-excitation with delta wave seen best in certain lead, you can add that here and so on. But this is the usual minimum is to have these 3 semi-orthogonal leads on the for the ECG. And then the intracardiac, usually we have an atrial signal. Now some for these quadripolar leads which are placed in the RA and RV, some operators prefer to put both proximal and distal. And one advantage could be that you can pace from distal but see the signal in proximal. But I find it just clutters up the screen. I prefer to just put 1 bipole. If you're putting 2 bipoles, some people also try to put 1 and 3 and 2 to 4, because that way your pacing and recording sites are not too distant. So that is also one way you can do. But I prefer to just put 1 bipolar recording from the atrium and 1 bipolar recording from the ventricle. And for the His, you can put 2 recordings or you can put 3 recordings, and you place them in one particular order. Usually now we prefer to place His proximal up, even though in this recording is the other way. So we usually now put a His proximal, mid, and distal. Now the coronary sinus, there are 2 schools of doing this. So some put the CS distal up, some put the CS proximal up. I put the CS proximal up, and I feel it makes more sense because the center of the tracing, if you see in a vertical fashion like this, the center of the tracing corresponds to the center of the heart here. So all this, the anteroseptal A lies in close relation to the posterior A. So it's easy to quickly compare whether your atrial activation is earlier here or here. And then the lateral ends are more towards the right atrium is more towards the upper part, left atrium is down towards the lower part. I feel this is a more intuitive way of doing, but of course, sometimes if you've been trained with doing in another way, you can follow whatever is comfortable for you. So, like I said, I mean, most publications in this also, you would see going this way. I think it makes more sense to do this. And even though those tracings I showed are in color, which is are in black and white, which is how we usually export it, on the display you see them in colors, and set colors in a very consistent way. You do it the same way. If you go to a different center and you're going to do a case also, I first see that the colors are set up the way I do, because you form quick pattern recognition when you see the colors. So at least the colors I use are white for the ECGs, RA and RV in red, CS is in green, and His and mapping in yellow. But again, it's individual preference, but just use a uniform color scheme and use it the same way every time so that you form that kind of quick pattern recognition. Now, an ablation page, again, you can set it up differently, but you try to reduce the number of signals you have on the ablation page. Use the signals which are more important for mapping. You want the unipolar, you want the bipolars, and use the remove all signals which you do not require, so that these signals can be kept large, not overlapping with others, and you can use them. After pages, you have to know what are the views or screens, and the most important display modes of views are real-time, review, and some of the triggered modes. Now, real-time is basically a screen where it is running continuously. It takes some time for you to start being able to see things as they happen in real time, but otherwise it's a very important screen to see. But a lot of the time you see on a review screen. Now, a review screen may be something that you manually pull up, like you just hit review, it'll freeze your current real time and show it on the review screen, or you go in the log and choose any time in the past and you can review that. But in addition, you have some of these triggered modes where it's specifically triggering on one beat and showing a sweep of signals from there. Now, this kind of trigger can be syncing to your extra stimulus, which is very useful. So you sometimes have an option of syncing to S1 or S2. You have to sync it to S2. So if you're for example looking for an AH jump, or you're looking to see whether your VA is decrementing, if you're always you're syncing to your V2 or syncing to your A2, then it's very easy to see how his AH interval is changing or the VA interval is changing. So learn to use this mode, how to set up an extra stimulus sync whenever you're doing an extra stimulus protocol. And the other that you should learn to set up is a triggered mode. So again, different systems have different ways of setting it up. It's easier to set up on some systems, but the basic idea is that you set up one signal as the trigger, and you set some amplitude on which will basically trigger it. So it's like sensing on a pacemaker. You're setting up some signal that you have to sense from. So whenever it senses this, it picks up a beat, and it uses that amplitude as a trigger point and shows it on a beat by beat basis. Extremely useful for mapping, because on a beat by beat you can see how your activation changes as you're moving your mapping catheter. So just as an illustration, I've just made this like a small GIF here. If you have a running screen like this is how it will look. So suppose you're mapping an atrial tachycardia and you're moving your catheter, trying to assess if you're getting better in relation to the P wave onset or you're not improving. Very difficult when you're doing a running screen. You have to keep pausing in between. But if you do like this on a triggered mode, you keep some reference signal as a trigger. It's constantly staying there while your mapping signal alone is moving, and then you can very easily identify if you're getting better or you're getting worse. So because I'm just telling this because some people train not to in their training still they're not using a triggered mode, and then never use a triggered mode. Very useful. So learn how to set up a triggered mode and use it. So sorry I went over time, but I thought that's an important session to discuss the basics. To summarize what we have discussed, we have briefly discussed patient evaluation, preparation, and what things to look at before the procedure, and how to handle the patient during the procedure, how to use imaging, specifically fluoroscopy, which is, I think, a very important, should be a very important part of training and ongoing learning to see what is your fluoroscopy use, how can you reduce your fluoroscopy use as newer systems come in, as you use 3D, whether you can cut down on your fluoroscopy. So about imaging, and then we have discussed about signals, what are bipolar, what are unipolar signals, how to set these up in the amplifier, and how to use the signals. So I think these form the basics of your EP study, and understanding these will form the basis for whatever is going to be discussed in the further sessions. Thank you very much.
Thank you, Dr. Raja. That was a fantastic session, and what a great way to begin this. I think people will really find this very useful. There are a good number of questions in the chat box. And Deepak, you and I, over the next 10 minutes, should we address those questions? I think that will be good. In the end, Deepak, I want you to have a poll of whether this session was A, useful, or B, not useful.
Sure, sir.
Okay. So, Raja, just fantastic. You covered almost everything. Maybe a couple of questions. Most of the questions are actually about noise, and this is what we face everywhere. And especially in my lab, when the cath lab is being set up or being new cath lab ordered, and we are setting up the lab, that is the first thing. We get the engineers in and get it cleared. All noise has to be managed properly. So there is one particular issue that rest of the time the system is clean, but the moment you step on the ablator, noise comes. So how do you address that? What is the problem here? What is happening?
Dr. Raja, you're muted.
Can you hear
Right.
us?
Yeah. I was not able to unmute myself, so that's why. Okay. Yeah. So I don't think there's different reasons for this kind of noise compared to other noise. It's part of an overall noisy lab. I think that if you get noise during the ablation, and we also get this sometimes, and sometimes it happens in some patients. It doesn't happen in some other patients. I really don't know how to tackle that. I think key is like what Dr. Ajay Naik said. When you set up the lab itself, have the engineers look at everything and make sure that everything is set up in a way that noise is reduced. If you have noise in an individual patient, either during ablation or without ablation, I think you have to check each source. So what we do is keep disconnecting everything that is there on the patient and see when you disconnect something, the noise will come down. See if the table is earthed well, every equipment is earthed. Disconnect the pulse oximeter, see if that makes a difference. Disconnect the other monitors, disconnect the defibrillator, and you'll usually find that it's something from there.
Yeah, so what I found in my experience, whenever this has happened, the ground patch on the patient, either there was too much gel applied, which was overflowing, or too less gel applied, or the other issue is, I think whenever the ablation catheter is used for pacing, if you have chosen the ablation distal for pacing, and you start ablating and you forget that you've chosen it for pacing, that noise can come in sometimes.
Yeah.
So that can be checked.
Yeah, that has to
Dr.
be
Ajay, I
done.
want to ask, sorry, you complete and then I'll
Sorry,
ask
no.
question more
I think
about
like you said, I mean, if it's specifically happening during ablation, that is one thing to see, because like I said there, you have to have these signals balanced, and when you open it for pacing, that doesn't happen. So you have to turn off pacing. Also check your ablation cables, ablation catheter. Sometimes it might be a problem in the cable. Also, you have to change your connector and see.
So
Do you
something
think
on the same line.
Do you think using different connector boxes, depending on where your signals are being recorded from? For example, you place your diagnostic catheters like ablation, like your CS, HRA, RV into one box, then take your HIS into a second box along with the ablation into a second box, might actually help this.
So I think in WorkMate, I think everything is in one box. I know in BARD, it used to be like two separate blocks, and sometimes you can't put some signals in the same block. But I think ultimately all of them go together. I'm not sure if that makes a difference.
EP Tracer can help you choose different boxes and do it.
Right.
But I have a feeling you are complicating problems for the technician, and you are likely to have issues during the case, particularly when you're in a hurry, and then you start wondering what is going on. So the technician has not plugged it in properly. So that can happen, and something had come into my mind, but I've forgotten. Okay, for patient preparation, shaving of the part or scrubbing with ether, spirit ether is probably not available. What do you do in your practice? What about the hair? Or clipping is enough? Shaving, clipping, what do you think?
Yeah, recommendation now is that using clippers is better, because of course it reduces abrasions and this. But our routine preparation, I think we are slowly trying to move to using disposable clippers on a routine basis. And preparation you can do with povidone iodine, but chlorhexidine may be a better way to prepare also. But usually of course, asepsis is not that much of an issue in EP procedures, but I think chlorhexidine scrub is probably best.
I would still recommend everybody to read up the book by Sunny Po, Warren Jackman's book on sniper's eye for ablation. That actually addresses a lot of problems about noise pretty systematically, and you can look into it for your own lab. Deepak, next question from you till I just go through what I wanted to ask.
Yeah, Shomu's made a very nice comment where he speaks about mapping focal VT or focal AT by keeping the ECG lead having the best QRS or P wave or the earliest intracardial signal nearby to the mapping catheter.
Yeah.
That kind of allows you to make a quick visual guesstimate. And Shomu, feel free to unmute yourself and share your views with the group. You are allowed to unmute.
It's okay. It's okay. Don't.
Yeah, it's a good point. I mean, you can ideally the P wave onset or QRS onset should be seen on a 12 lead ECG. So you can go to the 12 lead page, gain it up, go to a faster speed, set the onset. Now see which lead clearly shows the onset, and then you can choose that lead on the mapping page. So that's basically what Dr. Shomu, I think, wants to say.
I think all of us have kind of worked with different labs, especially if you're not doing it in the same facility every time. and a lot of earthing problems come in. So one of the things that we've noticed at that point is using some kind of an earthing where you try maybe a coronary wire and try to make it fixed to the ground, and those kind of reduce the general ambient noise within the recording systems, especially for those who are using portable ECG EP systems and they're doing cases in multiple hospitals. That remains one of the ways that we found useful to reduce the noise that is ambient. And of course,
Another culprit is generally defibrillator and infusion pumps when they are hooked into the AC outlet.
defibrillators are
Once you
not good.
unplug them, then they go to DC on battery, and that AC issue doesn't come up. So that helps.
One very unique source of noise that we had found on a case was the X-ray system. So if you kind of took the X-ray system into RAO, you would get significant noise without being able to see any signal on the intracardiacs. But when you took it in LAO, it kind of went off. You could raise up your eye, so that actually helps. But yes, this was also in the setting of a 3D system being used. So I would imagine there are multiple sources involved there. And again, if I'm not wrong, the J&J system allows you to get signals from the electroanatomical system itself. Whereas when it comes to the Abbott system, it kind of bifurcates at the beginning. So you have a feed going into the electroanatomical system and a feed going into the 2D recording system. So making sure that the J&J system also is actually a good system and there is no problem within that system is very important to see your signals on the 2D, especially if you are looking at 3D electroanatomical systems for your cases.
Okay, just the next point was regarding heparin use and ACT. Personally, I use heparin in all my patients. You have your own preferences depending on your protocols. Do you do ACT often in your cases? And if so, how frequently? And what is your heparin protocol?
So we do ACT in simple left-sided procedures if the procedure is prolonged, like you're in the left atrium for more than half an hour, which is unusual for simple cases like a pathway ablation. But definitely for all atrial fibrillation, left ventricular tachycardias, so we check ACTs, and we try to give 100 units per kg in the beginning itself, check an ACT after about 15 to 20 minutes, and keep checking every 15-20 minutes till your ACT is 300 to 350. If you give a larger loading dose, we usually find that you reach there quickly, and then we maintain it between 300 and 350.
Do you have a protocol about doing a handheld echo after the procedure, especially left-sided cases or complicated cases?
We have the echo machine with us for all cases where the transeptal is being done, but we don't routinely see an echo. Because if pressures are all right, we don't usually this. But yeah, it is something that can be done, because sometimes there may be a slow leak, and if you miss that and patient goes out after half an hour, the patient may crash. So it's not a bad idea to do a routine echo for sure.
Just a pointer that I'd like to add, for those who are listening and those who want to listen to my words, that any hypertension after any cardiac procedure, just get an echo done.
Yeah.
Don't presume that it is vasovagal. If it is vasovagal, of course, things are okay. But any hypertension, just get an echo done. Only the primary operator knows what he has done in the lab. Nobody else in the ICU, etc., is aware. So get an echo done, rule out a pericardial effusion. And if there is an effusion, I am a little more aggressive. I do pericardiocentesis, even though there doesn't seem to be tamponade, because it's better doing it then and there than at 2 in the morning.
The other has made a point on the setting up automatic RR and VV intervals. Actually, I wanted to mention that I didn't do that. So you can set up in the system automatic measurement of beat to beat RR intervals or VV intervals and AA intervals. And that's a very good point. You do that, it helps with a lot of things. If you're putting PVCs during a tachycardia and scanning diastole, you can just keep looking at the AA intervals instead of measuring them each time. So that's a good point. That's something that you can do routinely.
It's a very important question on the Q&A part, where somebody is asked, how does reuse of catheters have an influence on EGM and ablation energy delivery? And how does that contribute to noise and so on and so forth? Very important question from our side. I do think reuse is a common practice. Thoughts, sir?
Yeah.
And everybody on this can actually give in their thoughts.
Yeah, it's a very pertinent question because it's not discussed otherwise in textbooks, but it's a practical issue that we face every day. So definitely, if there is noise and you've eliminated other sources, if your catheter is used multiple times, it's better to change it. It's preferable to have a tab on how often you're reusing a catheter and have a limited number of reuses. And with ablation catheter, what we find is sometimes deflection breaks, sometimes the thermistor doesn't work, so your temperature this doesn't work. Not sure you usually end up with ineffective ablation just because of reuse. I think it's unlikely to happen without some other markers coming up. Like usually temperature sensor might go or impedance measurements might go wrong. So I think that's unlikely to happen, but it's better to limit reuse, keep a certain number of reuses, and if there are any other issues that you see like impedance, temperature problems, to just change the catheter. That is what I would say.
Generally, there is no other explanation. You can get rid of the catheter. If there's physical damage to the catheter,
of course,
just get rid of the catheter. Another point regarding the noise of ablation is inadvertently, if your ablation connector has become wet for some reason, saline dripping from the infusion pump, which is next to the connector box, that can give rise to noise. And this can happen even with new catheters. So then you cannot always blame reuse for noise. So any fluid in the connector box or in the connectors when you're plugging it into the ablator, that all can be a problem. Regarding USG use for vascular access, do you use it often? In India, we hardly ever do that.
Yeah.
But is that a practice that we should try to adopt?
Yeah. So we are not using, but like you said, we have to use. And whenever we go to the West, it's standard of care there, and they're using it. I think we should slowly move to using it. We also.
It's quite informative when you kind of use the ultrasound for access. At least from my practice, I've always used it, and it makes understanding of the anatomy much more easier. I know taking a femoral access or taking a jugular is not really a challenge most of the times, but I always feel that if you can do it right the first time, why not? Yeah. And it's quite incredible to see the number of times the vein is actually hiding behind the artery, or the jugular vein is behind the sternocleidomastoid. Some nice insights into anatomy there. But yeah, I would kind of go for that. And a lot of times as a kind of jugaad solution, as we call, just having a glove on top of your probe and using some kind of a intermittent medium, like say betadine, actually allows you to get great images. You don't really always need the vascular probe. Even the echo probe with a glove on top of it with a interface of say betadine actually gives you some excellent imaging. That's something that we could try, not really have to wait for the vascular probe.
I keep reminding myself to use ultrasound, and I think I will bring it into practice now onwards. But it is better if you want to get it into your workflow to do it for simple places first. Your routine, even femoral access, just get used to it. And then when you really need it for a difficult case, you will not be trying to get through teething troubles. So use it in your simple cases. Get used to the imaging.
How often do you, I mean, there is a interesting comment where some centers are using this spacing of 10, 10, 10, 10 quadripolar catheter, which records His in the proximal electrodes, RV in the distal electrodes. What are your thoughts about these large spaced? I mean, there's also those duodecapolar catheters, which you place on the free wall where you kind of record everything in the atrium. And I remember a very senior consultant once telling me that those seem to record everything in the heart and not just the atrium. So any thoughts on how you choose a catheter for spacing? And is it based mainly on the kind of case you're doing, or what are your thoughts?
So, like I said, I think the the relationship between the signal and spacing is a little complicated. The very narrow spacing gives you very high location fidelity. So over space, you can follow things. And the wider space you go, your amplitudes are larger, but you also lose this kind of spatial resolution. So I prefer to always use 252. So it gives you a 2 mm spacing also, and you also get this 5 mm spacing between electrodes. But you can sometimes use a 222 with multiple, like a hexapolar or even a decapolar in the His region when you want very more activation, like you want to see for a atriofascicular pathway or some other things. I am not aware of this thing of trying to use one catheter with wide spacing to record both atrium and His. I would think it makes it very, I don't know, it probably reduces flexibility, but I've never done that, so I don't know. It is tempting, of course, that you reduce one catheter, but I haven't done that.
I've used the duodecapolar going right from the right free wall through the isthmus, through the CS os into the distal CS. So you have
Yeah.
one catheter just
Yeah.
recording everything.
Yeah, that is fine.
Deepak, I think we've run through the questions, isn't it?
Yep,
Anything
just
else that comes up?
one from Dr. Chandrasekharan, post-procedure left-sided ablation, anticoagulation protocol. And Dr.
Post
Yadav,
procedure.
anticoagulation protocol.
Post procedure antiplatelet or anticoagulation, left-sided procedures.
Yeah, so post procedure, the again, the usual guideline is to give them aspirin for at least 6 weeks, which is what we do for patients who had a left-sided ablation. Patients with LV dysfunction or atrial fibrillation, and of course flutters who've had ablation, you have to anticoagulate them. Otherwise, antiplatelets.
Dr. Yadvi has a question. What's your preferred choice? I know you've mentioned that during the course of the talk.
Yeah.
Is
I
it
think-
easy from the neck or from the groin?
I mean, people who do both can probably comment. I mean, I do most from femoral. Easier is, of course, from putting it from above. But at the same time, putting it from below is also easy. Like 99% of the time you'll get it. And in terms of operator comfort, patient comfort, I think it's easier to do everything from femoral. So that is how I prefer to do it. But people who put it from above, like I said, one is it sort of stays a little away from the other catheters, and also it reduces one femoral puncture. So you have a little more space in the femoral side. So I think that is how it happens. I think maybe you can mention how you prefer and how you do things, so that.
If I may add to that, generally
Yeah.
for CS, I use a deflectable DECA, which is 5 French. It is a nice
Okay.
catheter, but it's a little flimsier, and sometimes it is not able to negotiate the eustachian valve or the CS valve.
Right.
So I actually use the ablation catheter, which is sturdier,
Yeah,
large
to enter.
to enter the CS,
Yeah.
and then the decapolar then goes and easily follows the
Right.
primary catheter.
So, while on the while on the topic of getting inside the CS, so let me just ask this: how different is it when you're trying to put in an ablation catheter versus a decapolar catheter? And if you have a bidirectional ablation catheter, what is it that you want to look at? Which curve that you're trying to look at to get in? I mean, you have the D and the F. Yeah, you have the D and the
ablation
F.
catheters are 7 French. They're have much more spine, so they are able to deflect all the intervening tissue to enter the CS, so that helps. And I use the larger curve, the F curve, to use it.
No, I do the same thing that Dr. Ajanayak said. So if you have difficulty with the CS catheter entering, sometimes the os, like you said, because of the valve or this, an ablation catheter is much better in negotiating entering. Once it is there in place, you can slide the decapolar alongside it and then remove the ablation. And usually you need a larger curve in patients with right atrial dilatation because of TR or an ASD. Otherwise, I think a medium to large D or F should be fine.
How does it work when you're trying to access the distal parts of the CS, the AIV? How do you maintain the ablation catheter in terms of being able to access the curve? I mean, it's easy to get into the proximal part, go up to around 3 o'clock. But then when you want to get in further in, so if, say, for example, mapping. So is that a way that you would like to position your catheter or use a specific sheath? Any thoughts?
So sometimes it goes in easily in the CS, but a lot of the times I prefer to use an Agilus. But you have to be gentle going in CS. You have to be very careful. So usually take the deflectable decapolar through the Agilus, put the decapolar inside, slowly thread the Agilis over it. And the decapolar, you can usually take it around the bend into the close to the anti-interventricular vein, take the Agilis there. Then it becomes a little atraumatic when introducing the ablation catheter. You have a lot of flexibility moving back and forth and changing the catheters and so on.
So there was a comment about IJV versus femoral. For IJV versus, I would say, subclavian axillary versus femoral. If I don't get anything through the femoral and I do have to go superior approach, I generally go right IJV because again, I'm in control of things. I don't need to cross and
Crossover, yeah.
crossover. I can manipulate the catheter. IJV catheter, the handle comes right up till the groin or up
Yeah.
to the chest.
Sure.
And I clip it there with a artery forceps to the sheet, so I can manipulate that easier. I generally try to minimize the movement of people in the lab, so they invariably stumble over cables and all, and that becomes a pain. And I like everything to be kept under my control, so I preferably do that.
Sure.
I am pretty type A regarding this. Oh, let me ask you something. Isoproterenol, how do you give it? Do you give as an infusion or do you give it as a bolus? What do you do?
So long back, we used to do it as a controlled, as a sort of uncontrolled infusion. Add it in the saline and give it. But we've switched to a controlled infusion with a syringe pump now. So we have a set dilution so that we know that 30 ml per hour will go at 1 mic per 1 mic. So we know the dose and we give it as a controlled infusion. So it's a little slower to start off the effect, but I think once you have an effect, you can maintain an effect of the same level without going too fast if you do that. So that's what we are doing now.
Have you had experience? I mean, both of you are people who've used it from the groin. There's an interesting question about prefixed CS catheters versus deflectable CS catheters. We kind of do a lot of it from the neck, and we find the prefixed CS catheters to be very useful, especially when given to fellows too. Provided they're using the proper views, getting it into the CS becomes much more easier. It also reaches the distal aspects of the coronary sinus anatomy. So yeah, Dr. Yadve, the prefixed is our choice when you're going from the neck for sure.
I prefer the deflectable irrespective because then I have the freedom to take the catheter anywhere else I want to. If I want to move it from the CS to the tricuspid annulus or free wall, I can do that. I can do it with the other things also, but it just makes life easier. For some reason, if I want to do LV pacing for a left-sided ablation, I can use a different decapolar or something, and that also is useful.
One last
So this
question
is a question from Saktivel. Can we use intracardiac versus IVC electrode as a reference for unipolar? Both perform same.
Once we use
IVC electrode instead of we want to sacrifice the catheter. So actually the EP tracer system has a way of including the intracardiac signal for unipolar, if that is for the unipolar. I think
once you
Warren
use
Jackman's lab, they use the special right atrial catheter where the
Which has
sixth
a-
electrode is far away in the IVC. They use it as a reference for the unipolar. What do you use?
no, if you use an intracardiac electrode, it's basically a bipolar recording because once your reference electrode should be an unvarying potential. So if I think what you're asking is you have an RA catheter, can you just use one of the electrodes of that as the reference? Then it's not unipolar. So it's a widely spaced bipolar then. So you have to choose a catheter which you do not require to keep in the heart, pull it down into the IVC and use that. Or like Dr. Ajanak said, there are specialized catheters where one electrode, because you want only the distal two bipoles, but there may be a proximal electrode which is placed very proximally so that you can keep the catheter in the RA, but one catheter remains in the IVC and you can use it as a reference. So, but if you use an intracardiac, it is not a true unipolar. It is a bipolar.
There is the Dr. Jackman question. How to set up A and V pacing simultaneously during tachycardia? How do you split those signals? How do you set it up? And which are the systems that allow you to do that?
Yeah, so it depends on the system you use. I mean, most systems they have multiple pacing channels. So many systems have 2 to 4 pacing channels, and you've already set up atrium as one channel, channel one, and say ventricle as channel two, and then you can select for pacing to happen from both channel one and two, and that can be with zero delay or with a delay also. So you have a lot of flexibility. So I think if you have difficulty, it might be only with a very basic system which does not allow you to do simultaneously. Then I think only way is to sort of put a Y connector or something so that it goes into both simultaneously. But generally, most systems will allow you
Let
to
me
do
give
it.
you a historical fact about this. 25 years ago, we used to use something called a Bloom stimulator.
Right.
Okay, it was a huge thing, externally connected, and we could choose which channels to use. Same 4 channels, and there you could do everything. You could do whatever you want, stimulate from 2 simultaneously and all. Of course, now everything is computer, electronic, keyboard based. So that is not possible now. But with the Bloom, we could do that.
Right. There we have another one.
Oh,
We still do have the Bloom.
Tarun Sridhar still has the Bloom. It's like using your manual car instead of your automatic nowadays. You think you are driving it.
Yeah, that's true.
Okay.
Good. I think we have run through the questions pretty good. I think this was a fantastic first session. Thank you, Dr. Raja. That was great. And this is just what we needed to start the series. Deepak, there is an astonished look on your face. Anything you
Yeah,
want?
because there's another question.
Okay.
This is so nice. Arun asks, what are the indicators that indicate that you have to discard the catheter and not reuse it after? So come on, this is something that we should. While we do that, I would like to draw everybody's attention to a very interesting study done by John. I think it was 4 years ago, where he actually looked at the electrical properties of the catheters after reuse, and the magic number is 12. So now,
What happens? They improve or
they worsen. They worsen. They do worsen.
Because I love some of my CS catheters over a few uses. They have learned their shape.
Correct.
From femoral, they automatically go into the CS.
Yes, yeah.
So is there plasticity on those catheters, Dr. Raja?
I'm sure there is.
I mean, do
See,
they
even the His catheters
shape retention?
even the His catheters over a period of time, they tend to become RV catheters.
Yeah.
Especially
yeah. With unidirectional catheters, the problem is that it stays fixed in some amount of deflection. Like you fully undeflected, it doesn't become straight. Number of uses may vary depending on the particular model and manufacturer. So I don't know if you can put one number for everything. But I think one way is to have a fixed number and say you discard at that time. But otherwise, if you're reusing, of course, you should physically see the catheter before you put it in. If the deflection is going to break through, we've had deflection cables cutting through, or the plastic is sort of degraded or it's wrinkled somewhere, then of course you should not use it. Otherwise, I think if you put it in and the electrical parameters are not good, you suspect it's due to the catheter reuse, again, you should discard it.
Yeah, very low threshold of discarding catheters.
Yeah,
I don't want anything to break inside the patient.
Has anybody had that though? Breaking a catheter within the heart?
No, it happens with obviously coronary luminal catheters, not with this.
Yeah, it doesn't break off because these, like I said, these are not hollow catheters. But one thing that we've seen, and which I think other people have also shown in the groups on this, is the deflection cable. Sometimes, if it's multiple uses and then you're deflecting very strongly, the deflection cable cuts through and comes out.
Yeah, that does. Oh, if the plastic wears through and the wires are jutting out, you might traumatize some part of the human tissue. So you don't want to do that.
Great. HD grid splines. There we go.
How come you're getting the chat box questions faster than I am?
Seeing the new ones. Yeah.
HD grid splines can break apparently. So. Okay, this has been really cool. Dr. Nayak, Dr. Raja, would you like to summarize and then?
Yeah, I think this was fantastic. This was a great beginning. for a great series. Thank you, Dr. Raja, for this fantastic session. And thank you, Deepak, for working so hard to get everybody in. And thank you, everybody in the IHRS EC and IHRS body for supporting. I think this will be great for worldwide teaching. In the chat box, I did see in the attendees, there are people from around the world. So that will be great. This is a great beginning. Thank you.
Thank you.
Thank you. Thank you, everyone, for being a part of this. And thank you for allowing us this opportunity to present before all of you. See you next month.
Oh, one last thing. I would welcome any suggestion for topics and for speakers for the next few sessions. We have already a few lined up, but yes, we can always incorporate, and Deepak will be happy to do that. Bye. Have a great Sunday
Bye.
morning.
Yeah.